This is Chapter 32, Spinal Cord Trauma. So I want to review anatomy of the spinal cord and spinal column, and I'll also talk about the physiology of what might happen if there were an injury to the area. So first, the cord itself. The spinal cord is a soft organ. It's part of our central nervous system, and it's actually a series of pathways built into this structure. And you can see from this diagram here on the screen, there's ascending tracts and descending tracts. So these messages are constantly going back and forth to maintain homeostasis, to keep your body the way it normally should be. The reason why we stress good, effective PMS checks on patients who have had some kind of mechanism of injury or that we suspect possible spinal injury is because you can see from this picture that there are motor pathways, there's light touch pathways, and then there's pain pathways. And when someone has a spinal column or a spinal cord injury, they might only affect one of these pathways. So if you would only check just one pathway or two pathways, you might miss the fact that this person does actually have spinal cord involvement, and they need to be treated at a trauma center and placed in spinal motion restriction. So when we do proper PMS checks, we're going to check the motor tract, the pain tract, and the light touch tract as well, including, of course, their pulses. Also, with this light touch tract, you can see from the picture of this human body right here, all those pathways that are drawn onto that human body, those are dermatome pathways. There's 30 of them in the human body, and they do vary slightly from person to person, but generally speaking, they're pretty accurate. So you can imagine if you encounter someone who has fallen off their bicycle or motorcycle, and they're awake and alert, and you're doing your pulse, motor, and sensation check, and they have good, strong pulses, they have good finger spread and pedal pushes and all that, good strong motor response. Also, when you apply a pinch to their extremities, they can feel you pinching them. But when you go and you do your light touch sensation, what you notice is that below the level of the calf, they can't feel you touching them. So that should be telling you that if you look from this picture, somewhere, if you look at where it might align, somewhere around the sacrum, maybe somewhere a little above, even lumbar possibly, there's some impingement of a nerve there because they've lost their sensation, that light touch sensation, below the level of that injury, essentially. So again, it's really important that we do proper PMS checks. Now, the spinal cord is made up of bone, and there's cartilage between each bone, and there's muscles and ligaments holding this all together. Down the center of the structure, of course, there's a tube or a hole, a foramen, I guess. And down this tube is where the spinal cord sits. Again, it's part of our central nervous system. It comes off of our brainstem. And if you look at the possibilities here, someone could have a spinal cord injury. The soft tissue is damaged, but the spinal column is completely intact. There's no deformities, there's no fractures, there's no crepitus, there's no tenderness. And on the other hand, someone who has a fractured spinal column, so meaning their vertebrae has been damaged, they might or might not have a spinal cord injury associated with that. So they can be actually exclusive to one another. Also, somewhere around the fourth or fifth cervical vertebrae, as you can see here on the picture, there's the phrenic nerve. And the phrenic nerve operates your diaphragm. And hopefully you remember from the pathophysiology lecture, the phrenic nerve provides about 60% of your breathing power and effort. So if you break your neck or you damage your phrenic nerve, then of course you could knock out more than half of your respiratory effort. And this is why people who have cervical spinal injuries, they wind up needing bag valve mask ventilations a lot of times if they're serious injuries. Now, when someone has a complete spinal cord transection, everything distal to that transection, all the innervation from the central nervous system is lost. So everything below the level of that cut is no longer receiving messages from the brain and brainstem. Now, because of this, depending on where this transection is, the higher up it is, the more parts of the body are involved. If this is a cervical transection, which is the most common you see, because the neck is the least supported and probably the most easily injured in a fall or an accident, everything distal, everything below that transection, let's say it's C5 or C4 or C6, whatever it might be, everything below that is not getting any kind of innervation, and the entire body just goes into this kind of mode of just trying to control itself without any kind of it's messages, essentially. So this is why when people have complete spinal cord injuries like this, especially that high up, their heart rate gets really slow because they no longer have the release of adrenaline to increase their heart rate. And they no longer have that innervation from the brainstem to breathe effectively or breathe at all. So they lose the respiratory effort. Also, because they can't release adrenaline, they can't vasoconstrict. So their blood vessels dilate and their blood pressure drops. So people that have these very high up spinal cord injuries in the cervical spinal region, they are paralyzed, distal to that area. They can't move their muscles. They can't breathe on their own. They have very low blood pressure, and their heart rate's very slow and ineffective. Because, again, the brain and brainstem are not innervating those structures. Now, all this stuff I described already is called neurogenic shock, also known as spinal shock. So you arrive on scene and there's a person who's fallen off their horse or fallen off their motorcycle or fallen off a ladder, and they're paralyzed from the neck down. What you might notice in your assessment is, one, they're not going to be breathing very effectively, which means they're probably going to need bag valve mask ventilations. Their blood pressure is going to be extremely low, might not even be palpable that low. Their pulse is going to be very, very slow because, again, there's not going to be that innervation through the adrenal response, that beta-1 response, essentially. And the skin that's below, the person's skin that's below the level of the transection, their skins are going to be flush, warm, and dry. Flush because all of their blood vessels have dilated out and making their skin kind of a reddish flush look. They're not going to sweat because they don't have the mechanism to sweat. They've lost that ability to sweat. And so you can see even though they're in shock, and normally you would define shock as someone being pale, cool, and diaphoretic, but that's only for someone who's going through some kind of blood loss, hemorrhagic shock. This is spinal shock. So you're not going to have that pale, cool, diaphoretic skins. The skins are going to be flush, warm, and dry because they don't have the adrenaline response that someone going through another form of shock might have. And of course, treatment for this would be bag valve mask ventilation, support their ABCs, and then transport them to a trauma center. Now, people have spinal cord injuries where the cord is not damaged in the sense that it's not cut or nicked, it's just bruised. And there's different types here. There's Brown-Séquard and anterior and central cord syndrome. What you might notice is that they just are odd presentations, like the Brown-Séquard. And I've never actually seen this in the field myself personally, or maybe I saw it in didn't notice it possibly, or didn't recognize it. But you have someone with this brown Sukara. This is the central one. It's the picture in the middle there, where just one part of the cord is affected. Because of one side of the cord's affected like that, you get unequal neurologic function. So they might have perfectly fine right arm movement, but weakness on the left side, and then they have a weak left arm and a weak right leg. It's just kind of a weird presentation that you might miss it because it doesn't present like a normal spinal cord injury, where usually everything distal to that injury is affected. You can see there's the anterior cord syndrome, like I mentioned before. The pain and motor pathways intact, but because it's that area of the cord that controls the light touch, they can't feel the light touch aspect of it. And the one on the very left, that's your cervical cord syndrome. Only the upper extremities are paralyzed, not the lower ones. So again, it's kind of odd presentations that we might miss in the field because we're not expecting these. We're expecting more the typical presentation of bilateral paralysis or weakness. So guidelines for mobilization, like when do we consider to immobilize a patient? What it really comes down to is, when in doubt, immobilize. It's a pretty benign process. If it's done correctly and safely, it's in no way harms the patient. It might be slightly uncomfortable for them, but it might be better for them in the end. So I'll give you a scenario. So you called out to this Jeep versus other car, and in the driver's seat of this vehicle is a 22-year-old male, restrained lap shoulder driver, was going about 40 miles an hour and struck this other vehicle. Patient has full recall of the event. You find him sitting in the driver's seat of the vehicle. He still has a seatbelt on. The car does not have any airbag, so it's not even an issue here. He's completely oriented. He has full recall of the event. He says that he has a little bit of neck tenderness. Now, right then and there, that should tell you that this person needs spinal motion restriction. They need a cervical collar. So at that point, while he's still sitting in the vehicle, you would check pulse, motor sensation the best you can. I know it'd be kind of awkward with the steering wheel there and taking his shoes off and all that, but you do the best you can. And at that point, you could put the gurney next to the driver's door. With your assistance, the person could turn, as long as he has no neurodeficits, as all his PMS is intact, he could turn carefully. He could stand, turn, and sit and lay down in your gurney. And that would, with a collar in place, with no neurodeficits and a collar in place, that would be an okay thing to do. Now, if the patient had neurodeficits, if you went through your PMS while he's sitting in the car and he has numbness to his legs or weakness to his extremities or paralysis, well, then there's no way you're going to move this guy or allow him to move himself anyway. So at that point, you'd have to extricate the patient using some kind of spine board or other device to get him out of the car. But as long as there's no neurodeficits, then yes, he needs a collar because he has neck pain. But we could have him step out of the vehicle, just take one step out, stand straight up, turn, and then sit on the gurney and then lay back with our assistance, and that would be acceptable spinal motion restriction. Now, what we use to place someone in spinal motion restriction can vary depending on your agency, the patient's presentation, your mood, the phase of the moon, the time of day, whatever it might be. Whatever you have on your ambulance or fire truck that works. KED sleds. This is the kedric extrication device, which I'll show you here in a couple of seconds. Obviously, a collar, some kind of hard collar. We don't use soft collars in the field. Hard collar, a gurney with full straps, a scoop stretcher, padded backboards. If for some reason, if they cannot lay flat due to the fact that they're obese or that they're short of breath, or there's some other reason why they cannot lay in a supine position, you can actually put them in a semi-Fowler position with a cervical collar in place on the gurney with full straps on, and that would be construed as modified spinal motion restriction. You would just have to document why the patient was placed in that position, that Fowler's position, in your documentation. Now, again, it just depends on what you think you need. Now, that's a scoop stretcher if you haven't seen it already, the upper left side there. So this person's lying on their back. You find them in a supine position on the grass. They have obvious neurodeficits, so you don't want to have them stand up. You don't want them to move because they've got some kind of spinal involvement. You size and fit a cervical collar, and then you take the scoop device and you scoop them up, and then you can transfer them to the gurney on that device, or you could even transfer them to a spine board and then remove that metal scoop for their comfort. I would highly recommend padding the spine board with blankets before you do that, to give them some comfort and fill any voids that might occur between their body and that flat board. You could, like you see down here in the lower right, you could technically, this person had fallen, they had no neurodeficits, but they had neck pain. You could put a collar on them, and you could lift them up and place them on the gurney, just as you sort of kind of see right there. Not the most ideal situation, but you can kind of get an idea of what you might be able to do there. Now, when it comes to who needs spinal stabilization, so if you encounter someone who's been involved in some type of traumatic event and they have no neurodeficits or complaints, so you've done a complete PMS check and everything's intact, they're less than 65 years of age, they're not altered in any way, they're completely oriented, full recall of the event, there's no drugs or alcohol that could possibly be inhibiting their ability to understand what's going on or feeling pain. They have no distracting injury. What I mean by that is, if this gentleman has fallen off his bicycle and broken his forearm, the pain from his forearm is a distracting injury. He's so focused on that pain in his arm, he might not notice, when you palpate his spine, he might not notice that he has neck pain or back pain. And when you do palpate this person's spine, there's no pain or tenderness to their back or their neck. So if all of these 6 things are basically negative, then you do not have to place this person in any form of spinal motion restriction. They don't even need a collar. If any one of these findings are positive, if they have neurodeficits, if they're over 65 years of age, if they have an altered mental status, if they're impaired by drugs or alcohol, if they have a distracting injury and they do have some kind of pain or tenderness, they need spinal motion restriction. Now, pediatrics are a little different. We use what's called NEC. And so we look at, we're talking about infants and small children here, toddlers, 5-year-old, 6-year-old. Generally speaking, if there was no altered level of consciousness reported, the patient had no time lost consciousness, they're alert and acting appropriate for their age and situation for you as you arrive on scene. There's no obvious injury, so there's nothing, no blood or abrasions to the head or deformities. And they're moving around spontaneously without any kind of impingement or range of motion. Kids, just like adults, if your neck or back hurts, you don't move. That's just the way it is. So if you see a kid moving around and twisting and moving and twisting their neck, and this child does not have any obvious impingement to their spinal column. And the actual mechanism was very minor. He fell off of his bicycle or tricycle, or mom was holding him in her arms while sitting down in a chair, and the child fell off onto the floor or something like that. Very minor mechanisms. Remember too that for kids up to about 6 or 8 years old, the majority of their spinal column is still cartilage. Very, very, very flexible, very, very, basically kids bounce, essentially, in most cases. So kids are very flexible. There's nothing really that is there to shatter because the bone hasn't completely, set until around 8 years of age. So little kids, 2-year-old, 3-year-old, 4-year-old, 5-year-old, infants, things like that, they in most cases, they do really well in falls because one, they don't know what's happening, so they relax and they just hit the ground. And two, they're basically just all cartilage. Now, pulse motor and light touch assessment. So again, we'll have a whole lab on this, but essentially we're going to check both upper extremities and both lower extremities before we place a person in spinal motion restriction, if that's what we do. And then once we have them in spinal motion restriction on the gurney with a full C-collar in place or a full spine board in place or whatever is appropriate for the patient, we're going to get a second PMS check before and after. If this person, after the first PMS check, you ruled out all need for spinal motion restriction, then you're doing fine. En route to the hospital, you could always ask the patient how they're doing. Are you feeling any new aches and pains? If they start complaining about their neck, gee, now my neck's starting to hurt a little bit. My back's getting a little, tight. Why not do another PMS check? Why not? Remember that when someone gets into an accident of some form, the body releases adrenaline. And for a period of 5 or 10 minutes after the accident, the body masks a lot of pain and discomfort. But after a while, as they're sitting there, as they're calming down, as the adrenaline starts to wear off, so to speak, they start feeling aches and pains. So don't be surprised, halfway to the hospital, they're suddenly complaining of neck pain now. If they do your PMS check again, put a collar on them, and just document it. It's not that big of a deal. Now, things that we can use for spinal motion restriction. The first thing, of course, is a cervical collar. Now, when it comes to the purpose basically is to keep the person's head in a neutral position. If the person, once a collar is properly placed on a patient, properly sized and placed, if they wanted to, they could move their head pretty freely. So basically what a collar is kind of a way of saying, hey, dummy, don't move your head. That's really what it comes down to. It's just keeping that head in a neutral position if that's what they want to do. But again, most people, if their neck hurts, the last thing they want to do is move their neck or their back. Sizing. Well, sizing, there's two general collars out there now. There's an adult collar and there's a pediatric collar. And each collar is adjustable to 4 different sizes. The thing about all this is don't think of these collars as adult and pediatric. Size them to the patient. I've gone to high school football games, and I've had 200-pound 16-year-olds. Well, he's a pediatric, but he's not going to fit into the little yellow thing there, so I'm going to put him on this larger collar. And I've gone to convalescent homes for 89-pound little old ladies. They're 90 years old, and they need the smaller pediatric collar. So really, what it comes down to is what collar fits the patient. Don't worry about whether it's an adult or a pediatric. Worry about that it's the proper fit for that patient. Makes sense. And whatever manufacturer your company uses, that's what you use. You learn how to use it. Some are better than others. They're all one-time use, throw away. And application, we'll have a whole lab on that. Proper sizing and fitting of the collar. Now, once you have that collar in place, you've done your pulse motor and sensation, you have a collar in place, you've got to move this person from some type of entrapment, out of their vehicle, out of their back room, off of the ground, whatever it might be. We can use all different kinds of devices. Now, we don't use full body spinal immobilization all that much anymore. The only time I ever consider using what you see here in this picture is if this person has obvious neurodeficits. They have paralysis to their extremities, weakness, numbness, and so they need to be protected. The only thing I would do differently here is I would place some padding between the board and the person. Some blankets work great. Anyone out there who's ever been on a spine board themselves knows how uncomfortable this is. Every single bone, pressure point, because you're on that board sometimes 30, 40 minutes before they x-ray you and get you off that board. It's very, very uncomfortable. So if you think this person needs to go on a spine board, and they're going to be on it for a while, before you place them on there, pad that board, fill those voids, pad those voids. But if they don't have any obvious neurodeficits, if they're ambulatory at scene, they can get up, they're walking around, or they can step out of their car, or they can stand up themselves. They really don't need full body immobilization. You could lay them supine on the gurney, just on the cot itself, with a collar on their neck and full straps, and that would be proper spinal motion restriction. You can see about padding the voids. You get a lot of little old men and little old ladies. They have kyphosis. You can see this, or lordosis sometimes, and you can see this gap, the blue line there, that's the spine board. Obviously the gray hair, that's the back of her head. That's a good probably 12 or 14-inch gap between those two surfaces. If you don't put some padding back there and fill all that void with blankets and pillows, she wouldn't do very well. Just getting a cervical collar on her safely would be difficult. So any void should be padded. We have always carry tons of blankets, tons of pillows. You can always borrow a blanket or a towel from the family if they're there, and fill those voids. Don't fit the patient to the board, fit the board to the patient. This is the sled again. This is the kedric extrication device. Not used so much anymore because of these new spinal motion restriction rules, but it still can play a role, especially if someone's in a vehicle like this and they have obvious paralysis. They should be removed in full spinal motion restriction with a collar and some type of short board like you see here. These kedric extrication devices can also be used as pelvic stabilization devices. So if someone has a broken pelvis, you can flip this thing upside down, invert it basically, and you can use the straps, the chest straps and the waist straps as a pelvic stabilization device. And it also works well on pediatrics, and hopefully with some lab time we'll be able to show you some modifications for that. Even though it wasn't really designed for those other purposes, it was really designed for auto extrication of an adult out of a vehicle. It does have some other uses. Special considerations, helmet removal. My only hope is when I go on a motorcycle or a bicycle accident or some type of sporting event where there's helmets involved, my only wish is that people remove their helmets before I get there. And it's a really high liability for us. If they're still on the patient, and like you see here, there's a full coverage helmet, and with that full coverage helmet, it doesn't have a flip up front. You can't really access their airway very well. The helmet's going to have to come off. I'll show you in the lab how to properly do it, but what they're doing here is pretty good. The one gentleman is holding the person's neck and face, keeping it neutral, while the other person is kind of twisting and sliding this helmet off, spreading the helmet to getting it over their ears and over their nose. And then once the helmet's removed, they'll have some type of blanket or padding to place under the back of the head to make up the difference between the back of the head and the ground, because there'll be about a 2-inch gap there left if the head's kept in that same position. So this is the same with bicycle helmets, it's the same with football helmets, same kind of technique. If you can leave them on, that's great, but in most cases they wind up coming off. And again, you can only hope that they're taken off by the owner before you get there. Now, football players, things have changed in the last couple of years. For years and years and years and years and years, I was always told, and we practiced it, and it was in the county protocols, is when you had a football player with a spinal injury, you left everything on them like you see here, and you take off the face mask. You have the coach or the sports medicine person unscrew it, or you cut it away, or whatever it might be. About 2 years ago, the County of San Diego has changed their policy. They want us to remove all of their safety gear prior to transport. And so how the protocol reads is, if you're at the scene of a sporting event like you see here, a football event or something similar, You're going to have the coach or the staff assist you removing this person's, all their padding, the helmet, their chest protector, whatever they've got on will come off. Then they'll go into spinal motion restriction, and then they'll go on the gurney to the hospital. Why this is, I don't really know. It wasn't really explained to us, but this is the new, well, 2 years old, I guess, sort of new county protocol. I don't know about other states. I don't know about other counties, but this is the county of San Diego standard. So with football injuries like this, you would have them take off all their gear rather than transporting like you see in the picture. And we're done with all this spinal stuff. Oh, maybe not. I take it back. Infants and children. So infants and children, if they do need, if they have neurodeficits, if they have impingement of their spinal column, if they have poor PMS, they're unconscious, a serious mechanism, you would put a collar on them, sizing them appropriately, and then they would go onto a spine board. There actually are pediatric spine boards like you see here, or you could use an adult spine board if you don't have one of these. You just have to pad behind the shoulder. So you take a blanket or a towel and you would add about 1 inch to 2 inches of padding, depending on the size of the child, from the shoulders to about the waist or even the buttocks. And that way it lifts up the child's torso, allowing that head to be in line and neutral position once you place them on the board. So for adults, you might place the padding behind the back of the head, whereas with kids, you'd place the padding on the shoulders and the upper back. Now we're done with chapter 32.